I wear a bunch of hats. Some of them are clinical and some of them are research. And the real reason I've been interested in this topic is both because I think it offers a way to kind of tailor therapy to the patient a little bit better. But also we do have a research interest, which I hope I'll make clear during the talk as well. Happy to be interrupted, but obviously we'll save time for questions at the end. I'm going to try to put a very detailed story into a clinical context, and I would say that half my slides are about that clinical context. But if I don't give you the clinical context, you won't really be interested in the detailed story. So here we go. Pharmacogenetics or pharmacogenomics, you probably in this audience know more about it than I do, is a way to look at the heterogeneity of how drugs matter to a patient. And so many drugs, the efficacy and safety of the drugs are going to be impacted by single nucleotide polymorphisms, SNPs, in drug metabolizing enzymes in particular. However, if we want to just take a look at that one piece, we also have to pay attention to there are other issues. There are drug transporters, there are other drug targets that can have the same heterogeneity, as well as germline or somatic mutations. And there are ways that you can modulate the target with exogenous forces, like other drugs you're taking. So when we think about pharmacogenetics, for the medical oncologist kind of thinks a little differently than the pharmacogenomicist. Okay, so an example of a problem in pharmacogenomics is that there were outliers who have bad events, and it's a real disaster for your drug. For example, Seldane is off the market because of a prolonged QT syndrome in rare cases, but obviously that's a very bad outcome. The way oncologists tend to think, especially breast oncologists, is we look at large trials, usually in the adjuvant setting. We're trying to add to the chance that the patient's cured by the surgeon. And we're looking at the whole population. And we're going to individualize decisions for the patients based on really small incremental benefits. So if you look at the numbers, the fine print on this slide for a trial that got us to give chemotherapy a little bit more frequently to people, we're looking at a lot of patients, 2,000 patients in the study. And the event rate difference is between 107 and 75 events, okay, which obviously matters if you're one of the 32 patients who benefited, but those other 75 were doing just fine. And that the kind of difference we're going to see with Cyp2D6 is going to be of that small magnitude. So medical oncologists make cancer treatment decisions based on a number of factors. The characteristics of the tumor, such as whether or not the estrogen receptor is present. That's a very important characteristic, but we've also got HER2 new expression. And those targets predict whether or not you're going to respond to targeted therapy. So we know that HER2 negative patients, in general, don't derive benefit from trastuzumab, and in general, estrogen receptor negative patients don't derive benefit from hormonal therapy. There's also the stage that the patient presents, meaning the size of the tumor, number of nodes involvement. That's a prognostic feature. That's not a target. And then we make therapeutic choices, and the one we're going to focus on today is making the choice between an aromatase inhibitor and tamoxifen, and those are abbreviated for most of the rest of the talk as an AI versus TAM. Obviously, you have to take into consideration, whenever you're treating a patient, their characteristics, their tolerance for things, their comorbidities, and their ability to activate and clear drugs. So we talked about the incremental progress that we see in breast cancer. The general way it gets played out most oftenly is that we find strategies that work in the metastatic setting. We look at a small number of patients where the stakes are very, very high. Patients either live or die or have their tumor shrink in response to therapy. Then we move to the neoadjuvant or adjuvant setting where we've got the help of the surgeon to go along with it. So you've got to use a lot more patients to prove your point. But that's where frankly, the money is in breast cancer, both the money meaning Sutton's Law, we want to go for the target, that's the most of our patients, but also that's where, drug companies tend to invest the most money because it's the most number of people that we treat. We then use extremely large trials to look at the prevention setting. And in general, a drug that doesn't work in the metastatic setting is unlikely to work in the prevention setting. Raloxifene is either a red herring or not an effective drug, depending on how you look at it in that situation. Raloxifene did not work in the metastatic setting, but seemed to be almost as good as tamoxifen in the prevention setting. So In breast cancer treatment, there have been several major advances. We now pretty routinely are looking at the genomic profile of the tumor, although this Oncotype-DX test is now being tested finally in a prospective trial that's going to involve over 18,000 women to see if the genomic profile can really predict outcome. But this could potentially supplant our usual pathologic review with just a genomic profile of the tumor. You can also, of course, profile the genes of the patient. That doesn't explain a lot in the breast cancer world, but it does explain a subset of patients who have a predilection to get cancer that have BRCA1 and 2 mutations. In particular, that would be the most common setting. But even if you have a BRCA1 or 2 mutation, we're very likely to cure you with the treatment. It doesn't mean that you're not going to respond to treatment. One could also look at the characteristics of your estrogen receptor, either in normal tissue or in the breast cancer itself. We've also had a huge improvement in targeted therapy. We've known for a really long time that ovarian suppression is a potent endocrine therapy for breast cancer. We've had tamoxifen now since the 70s, and we now have third-generation aromatase inhibitors. We've had these for about a decade, but they've really only become commonplace in the adjuvant setting in the last few years, and they are an incremental improvement over tamoxifen. However, one argument might be that if we were to actually profile the patients more carefully and know who could actually activate their tamoxifen, maybe those patients wouldn't need the more expensive and different side effect mix of taking an aromatase inhibitor. And the pharmacogenomic profile that we're going to suggest is the Cyp2D6 pathway. As you probably know, the majority of drugs are metabolized by microsomal enzymes in the liver and the small intestine. And the cytochrome P450 CYP system is responsible for activating and metabolizing many drugs. Cyp2D6 has many variants and is involved in the metabolism of approximately 25% of clinically used medications. I deliberately didn't put a number of patients on the slide who have abnormal Cyp2D6 metabolism because that's not exactly known. It's roughly 10%, but we'll get into some more specifics about it. If you're a practicing clinician and you want to sort of know if it's known whether there's a drug-drug interaction, one place to look is the website that I've listed at the bottom, and this is from Indiana University, and it's Dave Flockhart's group, who is probably the most successful pharmacogenomic researcher in the country. And many of the publications that I'm going to talk to you about have his name on them. So when you ingest tamoxifen or any other SERM or really any other pill, it goes into your gut, and you absorb a certain percentage of it, and you need to activate it. And this is just to humble you and make you realize that it's not just a simple process of ingesting the drug and hoping that every patient has the same outcome. The phase 1 CYP metabolism occurs mostly in the liver, and that's really what we're referring to here when we categorize Cyp2D6 activation. So the current role of tamoxifen worldwide is that it is the most common adjuvant therapy, given it's cheap and it's generally well tolerated. It is the only proven therapy for men with estrogen receptor positive breast cancer. It's also the only proven therapy for premenopausal women and really perimenopausal women with ER positive breast cancer. Totally inappropriate for ER negative breast cancer. It's also used for prevention, including DCIS. It's frequently given as adjuvant therapy. Most patients don't end up taking it for prevention. There are many, many people who could take tamoxifen for prevention, but most people don't like the risk-benefit profile when they actually look closely at it. It's also used in metastatic treatment, and even though most of us are giving aromatase inhibitors as first-line therapy in the metastatic setting, if your patient responds to an aromatase inhibitor, they are very likely to respond to second-line endocrine therapy, and probably the next best drug is tamoxifen. So it's an important drug even now in the modern era when we have a few other drug choices. So this is another example of the incremental benefits, and this is why many clinicians are giving aromatase inhibitors initially. This is just one piece of a large international study that's looking at giving an AI versus tamoxifen, and also giving there are different parts of the study that have yet to mature that involve the sequential therapy of these drugs. But when you look at the fine print, you see that there's really very little difference between the two lines. They're really actually quite close together, but the disease-free survival does show an advantage for the aromatase inhibitor letrozole here, but it's to the tune of 84 versus 81%. So there's still a lot of people who would have benefited from either therapy. And when we look at the entire conglomerate of patients, there's no difference in survival. That's what OS, overall survival, stands for. However, when you look at the node-positive patients, the patient who had more risk to begin with, there is a difference in survival between tamoxifen and letrozole. So what's the downside of taking an aromatase inhibitor? Well, tamoxifen is an estrogen receptor blocker that blocks estrogen binding to breast tissue and breast cancer cells, but actually elsewhere in the body it kind of acts like estrogen. So aromatase inhibitors are just estrogen depletion, profound estrogen depletion in a postmenopausal woman. They are not going to be effective or even FDA approved in a premenopausal or perimenopausal patient. So when you lose estrogen, you get bone density loss, you probably get increased in cholesterol, and you may get some cardiac risk out of that. You get joint aches, musculoskeletal complaints that are sort of an amplification of what happens to people when they go through menopause, vaginal dryness, and potentially more menopausal symptoms. And of course, they're expensive because they're new drugs. So this is the kind of risk-benefit profile I think about when I talk to a patient and counsel them about the option of either endocrine therapy. Because most patients are going to be breast cancer survivors, it's imperative that you have a conversation about this. Most people only see cancer in the headline and are willing to, quote, do anything, but I think it's a disservice if we're going to have a lot of breast cancer survivors who are going to have hip fractures and compression fractures of the spine because they decided to be very aggressive about their stage 1 cancer. So I think it's imperative that you have a balanced decision, and this is why we're still awaiting trial from some crossover studies where patients get TAM for a period of time, then an aromatase inhibitor, or even vice versa. So I think that in the area of what we like to call personalized medicine, we'll look at all these things, tumor characteristics, patient's characteristics, and issues of acquired resistance to help patients make a decision. And I think that Cyp2D6 kind of fits in here. One of the things that I think we're going to need to learn a little bit more about is whether there are characteristics of the estrogen receptor that might actually suggest that certain patients would benefit more greatly from one strategy or another. So if we look at tamoxifen's mechanism of action, this is kind of what I learned in medical school, is that, estrogen binds to the estrogen receptor, and that's an intranuclear receptor, and so it takes a series of genetic events to happen downstream in order to activate the signal from estrogen. And tamoxifen can block that estrogen signal in the presence of estrogen, so you can give it to a premenopausal woman. And it's going to have a positive effect on the bone, on the liver. That's why the cholesterol is going to go down. And it's going to actually stimulate the uterus, which is one of the problems because you get uterine bleeding and very rarely uterine cancer. It's antagonistic in the breast and in the CNS, so that may explain the hot flashes. The benefit there is that if you're trying to prevent breast cancer metastases, the brain is one of the sites you'd really like the cancer not to come back into, and tamoxifen and the aromatase inhibitors do cross the blood-brain barrier. So this is kind of the simplified version of tamoxifen metabolism, but notice that Cyp2D6 is in there, that's sort of how you activate it, and the thought was that you activate it to 4-hydroxytamoxifen. So we kind of went over some of this, so I'm going to skip through some of it. But when you're thinking about the estrogen receptor and really the receptivity of the target to your drug therapy, we've had a chance to look at experimental imaging of estrogen, and we'll be doing an IND trial of the isotope in the very near future. So we've had a chance to look at how well a tumor can concentrate estrogen. I'd like to call that functionality, but it's really just concentrating estrogen. It's not the ability to regulate downstream events. And certainly there are other growth factors like HER2 that even if you block estrogen effectively are going to still drive proliferation of the cancer cell and make your hormonal therapy ineffective. There's also an issue, which we're going to get into here, about whether or not if the patient is taking something that might interfere with Cyp2D6 metabolism and they fail to activate tamoxifen, then they're not going to derive benefit from the drug because they're actually taking a drug that interferes with the metabolism. Cyp2D6 is a high avidity, easily saturable enzyme, and so if another drug is getting in the way, you lose the ability of the pathway to activate. So a sort of more complicated version of the tamoxifen metabolic pathway has emerged. This was published in 2005 and probably is yet now obsolete. But in general, one way to think about this is you start with tamoxifen and you activate it, and actually I think you take the top of the arrows over to 4-hydroxytamoxifen, but you probably need to get it all the way over here to endoxifen. And notice that both these routes involve Cyp2D6. When we look at Cyp2D6 in the population using a probe drug for Cyp2D6, this is spartine, we see that there are sort of 4 categories of patients. There are people who, most people, if we had to bet, most people would be in the extensive metabolizer category. They have 1 or maybe 2 copies of a functional gene that allows them to activate tamoxifen or activate or metabolize whatever other drug is under consideration. There are very few patients who are ultra-metabolizers, and as far as tamoxifen is concerned, that's not an issue. But for some other issues like codeine, ultra-metabolizers can be a problem, and that's a New England Journal paper about an unfortunate series of events that happened to people who were actually getting too much of the narcotic because they were ultra-metabolizers, and it can be seen in certain ethnic populations. But what we're concerned about is the intermediate and poor metabolizers, whether they're getting enough activation of the drug. And so you can see from this graph that that's roughly 10% in this paper. But we probably don't know enough about this to really know what it is. And there are certain populations where we seem to see more folks who have impaired metabolism of the intermediate or poor metabolizer flavor. So I've had the opportunity to work with, and actually thanks to them for the slides in many of these cases, this group that's called COBRA, which is a NIH-funded group that's a consortium between Indiana, University of Michigan, Hopkins, Georgetown, and the Mayo and Baylor. And really, everybody was at Indiana at one point, and they've all sort of spread out to different sites in the country. And it's a breast cancer group that's had a chance to look at in vitro systems, including hepatic microsomes, as well as in vivo levels of drug and drug metabolites. And I'm going to share some of their research findings with you. There are a few other groups that I'll try to be clear about who's done what, but the bulk of the work has been done by this group. And what they've shown is that the most abundant anti-estrogenic metabolites of tamoxifen, which are more potent than tamoxifen, are 4-hydroxytamoxifen and a compound they call endoxifen. And both of them actually have a higher avidity for the estrogen receptor than estradiol and tamoxifen, and are therefore more potent antagonists than tamoxifen. So when we look at binding in again in vitro system, if you look at the fuchsia bright pink line, that's estradiol. And 4-hydroxytamoxifen comes in as a greater inhibitor. If you look at where tamoxifen is, it's far out here in the light pink. These drugs out here, these metabolites are likely to be less active. And this is sort of the old news about tamoxifen metabolism. But the new news is that the COBRA group looked at HPLC and found that actually there was another peak right next to 4-hydroxytamoxifen that was a greater peak. And that was called drug X at one point. It's really 4-hydroxy and desmethyltamoxifen, not a catchy name, so it's now called endoxifen, and they were the ones who named it. And their theory is that this is the primary potent metabolite of tamoxifen in vivo. In vitro, it suppresses cell growth better than tamoxifen and of the potency of 4-hydroxytamoxifen. And when you take an inhibitor of Cyp2D6, such as paroxetine, you're going to selectively suppress endoxifen, but not the other metabolites. So if Cyp2D6 matters, you have to believe that endoxifen is the most important metabolite. If 4-hydroxytamoxifen is the most important metabolite, then Cyp2D6 probably doesn't matter clinically. So, and this is just the same data shown by HPLC. So if we look at, in general, so we're going to break the 75 different types of mutants into categories, which are sort of wild type. Wild type star 4 is the most common mutations, and then if you're homozygous for the mutant Cyp2D6, you're star 4, star 4. And if you look at that and you look at plasma endoxifen levels, they vary by the allelic frequency. And moreover, if you take an inhibitor of Cyp2D6, you take someone who is usually a wild type with a nice high level of endoxifen and bring them down closer to a homozygous for the deleterious mutation patient. And so this is the problem, is that clinical oncologists and others use drugs like paroxetine to treat hot flashes. And so they're inhibiting the very drug that they wish to be giving. Okay, so does all this have an impact on patient care? That's what's really important here. What are the patient outcomes and what are the toxicity benefits? Well, there are a couple interesting studies to talk about. One, in the prevention setting, is called the WELL study, which took breast cancer survivors, and they were randomized to a standard of care, so they got a little bit of counsel about their diet, or an extreme vegetable intervention. This involved way more than the 5 fruits and vegetables that are recommended. This involved vegetable juice and actually a really aggressive program that you have to wonder about the compliance of, but that was handled in the study. And there was no outcome. So all those patients took all their vegetables and didn't have an improvement in overall survival or disease-free survival. Potentially because they were already cured by their surgery, but for whatever reason, the study confirmed the null hypothesis. So, but there was an interesting finding in there, which was that these patients, all of whom were taking tamoxifen, some of them got hot flashes and some of them didn't. And it turned out that the patients who got the hot flashes tended to be the ones who did better. So are these the patients who are better able to activate tamoxifen? Rhetorical question. I actually think that's not the whole story. I don't think you need to have a hot flash to benefit, but it's just an interesting prevention story. And really it's an adjuvant study, but I think of it as more as prevention. Okay, now, then this is a true adjuvant study. This was years ago, because you see by the group number, this is the NCCTG, which includes the Mayo Group, and that includes Mayo, Florida. That is one of our large cooperative groups in this country. In 1989 was when this trial was conceived, which is why the study names is given by the first number 89. So these patients were postmenopausal women with early breast cancer who were randomized to either receive 5 years of tamoxifen, the standard of care, or 5 years of tamoxifen plus halotestin, which is an androgen. And the reason this study was done is that that was actually shown to be a superior strategy in the metastatic setting. Once again, this study actually proved the null hypothesis, and it was no better. However, the COBRA group went back and looked carefully at the Cyp2D6 genotype in the patients in this study. They looked at just the tamoxifen monotherapy arm for simplicity because we don't really know what the effect of adding the androgen was to it. That's 256 patients. They looked at formalin-fixed paraffin-embedded tumors, and the reason this was a JCO publication is that it wasn't previously known that you could get the genotype out of the paraffin block, but they did in most patients. And they found that the prevalence of the deleterious mutation was 7% in this study sample, and that those patients who didn't have the deleterious mutation did better. And the patients who had wild-type genes for Cyp2D6 were more likely to have hot flashes than the patients with the mutation. So when the patient's having a hot flash, you can tell them, oh, that means the drug is working. Okay, they then went back and wanted to look into one other issue, because what we've seen is that Cyp2D6 is a pathway that's involved for paroxetine and fluoxetine metabolism, and if you take paroxetine or fluoxetine, you're going to have actually lower levels of endoxifen in your body. If you take venlafaxine, you're going to have near wild-type levels. So they went back and looked at the patients, actually went back to the chart notes to figure out how many patients were actually taking an inhibitor. Okay, and when they went back and did that, they found out that the splay in the survival curves actually became a little bit more impressive. So they published the original work from the paraffin blocks in 2005. This was published this year, adding the addition of not just genomic profile, but whether or not they were taking an inhibitor to the patient population. And they found that the extensive metabolizers did better in terms of time to breast recurrence, and we'll look at a few other curves, than the intermediate metabolizers or than the poor metabolizers. Or the poor metabolizer would be a patient with normal genes taking a potent inhibitor. Relapse-free survival, there's also a stratification. Again, this is 256 patients, but this is important because it's an adjuvant study. It's retrospective in nature. This wasn't the original aim of the study conceived in 1989, but it's a very controlled population. When we look at breast cancer recurrence, you generally see a peak early at about 2 years. And the poor or intermediate metabolizers or patients taking an inhibitor had that peak of early recurrence. The patients who could activate their tamoxifen, that peak was lessened and pushed out farther, suggesting that they were actually getting more therapeutic benefit from tamoxifen. And so this is the main data that has pushed this issue of Cyp2D6 testing. And there is talk that there will be a black box warning, a further black box warning on tamoxifen regarding this issue, and that actually some insurers will refuse to pay for tamoxifen without Cyp2D6 testing. So this issue is a little bit pressing, although none of those two things are reality at this point. There's just a discussion about it. So what's the impact in metastatic disease? We don't have much data, but I think it's important to tell you what we have. This is a Korean study in which a quarter of the patients were found to have Cyp2D6 mutations. And they looked at adjuvant patients, and they also looked at metastatic patients. And in the metastatic patients, patients who couldn't activate tamoxifen had a difference in time to progression. That's what TTP stands for, which is really important. That's quality of life and probably survival for many patients. So, aromatase inhibitors, as we talked about, lower levels of estrogen in postmenopausal women. And this is kind of a cartoon of the pathway. There are a lot of steps in between. Normal people, men and women have detectable level of circulating androgens. We convert them to estrogens in the absence of an ovary, meaning postmenopausal women. And that happens in tissues, and that's probably the most important store of where drug-activating enzymes are in vivo. Of course, it's all important in a breast cell or a breast cancer cell, but the liver is where the activation of tamoxifen occurs. Just to emphasize that there's some downstream effects, there's more to it than just getting to the receptor in the cell nucleus. The plot is clearly thicker than what I've told you here, in that if you take a look here, this is 3 months treatment of letrozole, one of the aromatase inhibitors, in 29 volunteers. And in general, the dark lines show you that levels are dropped dramatically. However, there are 2 outliers in this study of 29 patients. And you've got to wonder whether those 2 patients have aberrant CYP19 metabolism, and that's why they're not getting the maximal effect of the drug. So just like we've learned a little bit about tamoxifen in the last 40 years, we're going to have to learn more about the aromatase inhibitors in the future and their metabolism. And I know this is a busy slide and it's somewhat unreadable, but the point is that in trying to block estrogen, we have drugs, we have drug targets, we have drug metabolizing enzymes. They're modulating proteins, and they're estrogen metabolizing enzymes in themselves. So the 2D6 piece is just one part of the story, and it's one part that we now know how to test. But when you're making a clinical decision or planning your next research study, we're going to have to look at all these other issues. And I will assure you that the Flockhart group is looking at aromatase and CYP19 next. So just to summarize what we know that Cyp2D6 metabolism is variable and actually now pretty well characterized by genotype. Endoxifen appears to be the critical tamoxifen metabolite, but we actually aren't positive about that. And we're in discussion with the COBRA group about using estrogen receptor imaging to see if that's really going to pan out in vivo. Certainly, endoxifen levels are impacted by the heterogeneity of Cyp2D6. People who are poor metabolizers seem to have fewer hot flashes and poorer outcomes with tamoxifen. SSRIs variably diminish Cyp2D6 activation, and venlafaxine seems to have the least impact. However, women who are having hot flashes and aren't on tamoxifen — hot flashes are a normal part of life and part of menopause for many people, so please don't think that the tamoxifen is the sole culprit of causing the hot flash, and the interaction of drugs like venlafaxine or other drugs we use for hot flashes is not essential. It's not essential that it interact with tamoxifen. So I think that it's an interesting observation about the hot flashes, but that's not the whole story. And I do think that there are patients who don't have hot flashes who benefit from things, and I think that if you're not using tamoxifen, it's fine to use a Cyp2D6 inhibitor to control the hot flash. And in fact, you're likely to be successful. Okay, so what we don't know is what's important here. We don't know prospectively in a randomized study whether or not pharmacogenomically targeted therapy selection is appropriate. And so there are people who are concerned about this and concerned that low levels of endoxifen or 4-hydroxytamoxifen may be sufficient to stimulate the estrogen receptor, and that we actually haven't seen — we've seen in cell lines that endoxifen is the critical is an active drug, and we've seen in humans that the levels seem to be different, but we haven't got an in vivo experiment, because they're hard to do, that endoxifen binding and the decrement in endoxifen level because of a Cyp2D6 inhibitor or a genomic presence in a patient with a abnormal Cyp2D6. We actually don't know that that's demonstrated. It's and that's probably why it isn't a black box warning yet. But we've been working with the intergroups to think about whether we could put forward a prospective study to actually take patients who are planning to take adjuvant therapy and help them make a treatment decision about tamoxifen versus an aromatase inhibitor by knowing their Cyp2D6 status. It's really possible that the intermediate metabolizers or the poor metabolizers may derive some benefit, and just that the other patients derive more benefit. And I think the big warning is that we really don't know a lot about aromatase inhibitor metabolism, and so I think we're just in the beginning of a new world where we're going to be able to look at these things and probably target the patient's metabolic pathways as a way to idealize treatment. So the other drugs that we use, what I like to call the European tamoxifen, toremifene, raloxifene, and these are all other SERMs, selective estrogen receptor down-modulating drugs. We don't know their metabolism as well as tamoxifen, nor the newer drugs, the SERDs, such as fulvestrant, or even the old drugs, such as progestins. So my suggestion about the clinical approach here is that I would avoid the class of SSRIs which reduce Cyp2D6 activation in a patient who you're prescribing tamoxifen to. And the two drugs in particular are paroxetine and fluoxetine that seem to be a drug that would be wise to avoid in this setting, and you could consider an alternative non-SSRI treatment or venlafaxine instead. I think I would consider Cyp2D6 genotyping as one variable in the decision-making regarding endocrine therapy, and of course we await more data from forthcoming studies. Thanks for your attention, and delighted to entertain questions.
Questions for Dr. Linden? So in the beginning you talked about a balance between all of the factors that help you decide clinically which treatments, where now there's the phenotypic aspect. Is it high up on the list? Lower?
I think it's low. I think that the work is really fascinating, but that was 250 patients. But those are very impressive splays in the curves. That's not — I didn't change the scale to show you that. That was a plenary talk at ASCO a couple years ago, and I think there's a good reason for it. So I think it's probably real, but it's too soon to tell. And now we have the problem of having to organize ourselves around the ability to do a prospective study. And one of the hang-ups is that what we usually do when we do studies is we put a patient on a drug and watch them over time. Now you got to watch what else they ingest. And that's really tricky to do. That's expensive, and it's complicated. It's a lot of teaching. Most of us don't know what all the Cyp2D6 inhibitors are. So you end up sort of saying, well, if the patient has a bunch of other medical issues, you better not put them on the study because they're going to need to take some other drug. So that it's the inhibitor piece. It's not just the genotype. That would be easy to set up prospectively. It's what other drugs are going to interfere.
And what about anecdotally?
What do I do? It really depends on other issues. Some patients have really strong feelings about going one way or another, and so I'm certainly not testing everybody. I just think it's my job to give you a balanced perspective. And when the patient sort of wants something that is going to be good for their breast cancer, but isn't going to rob them of estrogen and is kind of interested in taking tamoxifen, then I start factoring this in. Clinically, the other problem is that there's a group of patients that just don't tolerate aromatase inhibitors, period. So they're going to take tamoxifen. And then you get into a problem because do you want to tell them that their genotype suggests that they won't benefit from it? So you got to sort of use your judgment about ordering the test. But I think if somebody really wants to know, I think it's very reasonable to use, and it is a pretty easy test to do. It's kind of a fact. You either have the gene or you don't. So I think it's pretty easy to implement.
Along the same lines, is there any discussion about using tamoxifen as therapeutic?
Yeah, which is when it's really hard to develop drugs. That's the problem. I mean, tamoxifen was actually a postcoital contraceptive. That was what it was designed to be, and then it was thought of as a fertility drug, and then it sort of got revived as a cancer drug. It was one of those inadvertent things, and it's a big deal to develop a drug. But yeah, I think if we figured this out, we could think about doing that, and then you're just sort of trying to go for some pure drug that doesn't need activation. But as we try to make more of our drugs oral, it becomes a huge issue. It's a huge issue with lopatinib. It's a huge issue with capecitabine. Drugs that patients love because of the convenience. The clinician is sort of wondering how much of it, not just how many pills are they taking, literally what's their compliance, but what's happening inside the patient and what happens when they have a fatty meal. Does it mess the whole thing up?
The way what you'd like is some immediate or very short-term biofeedback that integrates all this. And I wonder along those lines, people look at the levels of FSH and LH, which is essentially the biofeedback from the brain.
Yeah, the problem with doing that is that how frequently do you measure the FSH and LH?
You could do it every day if you want to.
I know, but that's where I think that's where that test is a problem. I mean,
But the question is, does it make a difference? In other words,
Right.
if you said, okay, I'm going to add a drug and I'm worried about it, or one that will change metabolism, you could then a week later check an FSH
Right.
potentially.
right. But what? So you're saying that you would believe the tamoxifen was working if their FSH went which way?
Would be very high. The notion is that you would be, you'd have your postmenopausal level that you'd expect, and ought to get even above that because you're hyper-stimulating.
See, the problem is that tamoxifen, it's just really a dirty story, actually. Tamoxifen raises some people's estradiol level a lot, to the point that it makes me nervous as a clinician. But really, we don't know what that part means either.
What I'm getting at is it's a testable hypothesis that would be hard to do. Okay?
Yeah, I'm just not. I'm not positive that that's the way. I mean, you're right. It is testable, but hormonal levels fluctuate, so I think you'd have to measure a lot. And I'm not positive what you really want, because given the agonist-antagonist effects of tamoxifen, I'm not sure exactly what the goal is. It's actually a simpler story with an AI. You do not want the patient looking premenopausal on the AI, although there are some people who would argue with that.
All right, no further questions. Dr. Linden, maybe we'll stay around for a few minutes if you have a question individual for us. Thank you.